Okay, I'm going to get started. All of you know me. I'm Tammy Hodges. I'm the RN. I'm a trauma program manager over at Baxter Health. I want to talk to you today about trauma systems, specifically more so about the Arkansas trauma system. Give you a definition of the trauma systems, how they are created, the levels of Arkansas trauma centers, and then the Arkansas trauma system. A trauma system is an organized, coordinated effort in a defined geographic area that delivers the full range of care to all injured patients, and it's integrated with the local public health system. This all started, the trauma systems were implemented back even in the Civil War. They needed a way to get the patients triaged to the aid stations and rapid transport to the field hospitals and the general hospitals. By today's standards, this kind of trauma system would be very standard, but it'd be very basic. However, that's how we have built on these trauma system is all of our data comes usually from the wars. Improvements to trauma care have come a long way from the lessons we learned from the wars, especially from the Iraq and over in Afghanistan because of all of the blast injuries from the IEDs. In the old trauma system, EMS used to stay and play. They'd start you two large bore IVs, pour in a lot of crystalloid fluids, turn everybody's blood to Kool-Aid. Thought we really did good. We got them to the hospital, and then in the long run, statistics showed that they all died. Now in EMS, it's more of we swoop and scoop. Grab the patient, get it in the back of the truck, do what you absolutely have to, don't give crystalloids, and get them to the hospital. Back in a long time ago, tourniquets were a thing. Everybody got a tourniquet. Then they said, well, everybody's losing limbs because we're putting these tourniquets on. So they quit using tourniquets. Then they figured out people was dying from bleeding out. So now the thing is we use tourniquets because it's better to lose a limb than to lose a life. Used to, they took the patient to OR. They fixed every bit of the injuries. Even if you had a finger fracture, they fixed your finger fracture to go along with taking your spleen out. And they realized that keeping patients in the OR that long, that it was causing bad outcomes. So now we'll take a patient that comes in through the ER that has a spleen fracture, liver lac, or whatever. We'll go up to OR, pack that, or take the spleen out, and then we may send them with an open abdomen with a wound vac onto a higher level of care to where that they do the rest of the things, and then it may be a week before they get all the fractures fixed. They've learned that the patients has better outcomes this way. Before the Arkansas trauma system was implemented, the statistics in Arkansas showed that 93% of pediatrics that was involved in trauma died at an outlying facility before they ever made it to a children's hospital. The length of stay for trauma patients in outlying facilities, especially like our level 4s, because I worked here and I lived through this, the average of getting a critical patient out was 4 hours because you couldn't get anybody to accept these patients. I had a patient that fell out of a tree stand, a 70-something-year-old man up here hunting, and he had a fractured pelvis and was bleeding, and it took me over 4 hours to get him out of the ER, even headed towards Memphis to the med. Our new goal is now less than 2 hours. Do we always meet that goal? Usually level 4s is pretty easy for them to meet that goal, especially with Fulton County having their own EMS to get patients out. Level 3s, not so much. Over at Baxter, we struggle. We have our own EMS, but we do a lot more studies. We may take them to OR, repair or pack, like I said, pack a liver, or whatever, and then move them on to a higher level of care. So ours is not always 2 hours. However, we're doing something during that 2 hours to save the patient's life, to get them to where they need to be. Before the Arkansas trauma system, 1 in 4 NVCs that were admitted died before discharge. Now it's 1 in 16. So we've come a long way. We were 48th in the US. Now we are 37th, which this may have changed over the last year. My data may be a little out, but as you can tell, coming that far in the short amount of time we have, we've made great strides. Dr. Todd Maxim, he lived in Texas, and he was instrumental in starting 2 programs in children's hospitals down there, making them a level 1. He studied in the past at UAMS, and he decided to move back to Little Rock and bring his family up. And he started as a trauma surgeon in Arkansas Children's Hospital and at UAMS. Dr. Ron Robertson, he is a trauma surgeon at UAMS. And Terry Collins, she has been at UAMS. She has been at UAMS for years. Lost my slide. Hang on just a minute. And her and Dr. Robinson and Dr. Todd got together, and they decided that we were the only one. There was 3 other states with us that did not have a trauma system, an organized trauma system. So they started working to figure out how they could get Arkansas a trauma system. What they did was they researched the other states and that had proven trauma systems, that was in states like our areas in South Dakota, Iowa, what'd you say? Minnesota, the rural areas. So they came up with a system that they thought would work, but then they had to find out a way that we could fund this. So they went to the Arkansas Department of Health and talked to them and got legislation to put in an Act 393, which was approved by legislation in 2009. Started into law in 2009. The other thing they said was, how are we going to fund this? It's going to take a lot of money. First of all, we need education for all of the physicians. We need education for nursing. We need education for EMS, first responders. We need a lot of equipment, new equipment, updated equipment for the hospitals and EMS. So they decided that they would do a tobacco tax. So they put into a, what's it called? What is it when they put in a
sin tax?
Yes, to where that they tax tobacco in the state of Arkansas. That's why if you go to Missouri to buy your tobacco, it's a lot cheaper than it is in the state of Arkansas. They decided they would do a survey. Every hospital and EMS agency would have to do a survey to be designated. And then to get redesignated, you would have to go through that survey again. And let me tell you, the survey is rigorous for hospitals. EMS, they only have to do 1 survey, and that's right up front. But we have to redesignate every 3 years in hospitals to stay designated. You fill out a PRQ, and me and Charity filled that out because we got redesignated just in October, and it was 112 pages long, and there was numerous questions on each page. It took us about 6 weeks to fill out this PRQ. It asks you questions of every doctor you have, every surgeon you have, every ortho, all their credentials. If they have ATLS, if they're up to date on their CMEs, they have to have 18 CMEs every 3 years. It's just numerous questions, how your hospital runs, so that when they come in to redesignate you, they spend 1 day and they already have all that data in front of them to where that they can go through basically and review charts. They pulled 18 charts and reviewed a nurse and a physician from a level 1 hospital came and redesignated us. The
Yeah.
Arkansas traumas
They do that every 3 years?
every 3 years.
Wow. We did
Yes.
2 years.
Last year,
The last one.
don't talk to us.
So where are y'all at right now?
We just got redesignated. We had 2 minor deficiencies. If you have any deficiencies, you get provisional. It doesn't matter if it's one physician, like 1 hour of CMEs, you get provisional. You have to put an action plan of how you're going to fix that, and then you have a year to fix it. We got one doctor we thought had ATLS, but it had expired. So that was 18 hours of CMEs that we were short. And then the other one was when you guys call us, say from Fulton County, we have 20 minutes to accept your patient or tell you we can't take that patient. 10 minutes if it's multi-system injuries.
Mhm.
If it's just a one ortho bone, something like that, we got 20.
Is that because we're so far out?
It's just, that's a rule for us that we have to accept your patient so that, because we're a higher level of care,
Mhm.
and Springfield has to accept ours within that amount of time. If, yes.
Okay.
And like if you guys call us and we need to pull up the PAC system in the middle of the night, the doctor's at home and she wants to look at those CTs or whatever over here, it takes longer than 20 minutes to pull up, get up in the middle of the night, get your PAC system up, look at them, and then accept the patient. So we got a deficiency for that. I put an action plan in. We got the doctor to do her CME, so that cleared that one. Then we put an action plan in. I talked to all my orthos and all of my neurosurgeons and asked them what they will and will not accept. And we put that list in the ED. That way the doctor don't have to look to see what it, kind of, they don't have to research so far to tell if we won't take a flail chest. So if they say on the other end, it's a flail chest, we know we can't accept that
What all
patient.
do you not take?
We do not take flail chest. If it's multi-system trauma, our orthos will not accept it if it's like a femur fracture, but yet they got a spleen lac, all of that stuff
Okay.
to go with it. Complex pelvis is about the only thing our orthos won't take, and some calcaneus fractures that's complicated. They want them to go to a higher level.
We won't know that on scene.
No, you're as far as EMS, the best thing you guys can do is make your best judgment. Call ATCC,
Mhm.
make your best judgment of where you think, if you think something's broke, take it to where you feel comfortable taking them.
Okay.
Because that's, and then we will make that decision of whether we transfer or not. The main thing is we do not want, you don't want a sideways transfer or you don't want double transfers. We don't want to accept a patient from Fulton County that's a stable patient and then have to transfer that patient on to Springfield because you got a family and the finances.
Mhm.
You got a family that's got to go from Fulton County to Baxter County.
Mhm.
Then you got a family that's got to go from here to Springfield, and some of them don't even have the money to get to Baxter County. Then you've got air flight or ambulance from the scene to here. Then you've got an ambulance from here to here, and then Baxter has to send them on. So it's a big expense to the system. And that's part of what the system is for, is to get the patient to the right care at the right time and save money, because that's why the health department really bought into this, is because most people that has traumatic brain injuries and all of that, they're going to end up on Medicaid and they're going to be on health care through the state for the
Okay.
rest of their life. So they figured if they could put some money into this to keep people from having these long-term issues, then it would cut back on money. The Arkansas trauma system has several layers. But the one that's unique to Arkansas is no other state has a call center like we have, to where we can call TraumaCom. It's contracted through MIMS in Little Rock. Every hospital has a dashboard. We update our dashboard regularly. If our CT scan goes down, we document we don't have it. If our surgeon is out for some reason, and that's only happened one time, we have to put that we don't have a surgeon, or we don't have ortho this day, or we don't have neuro this day. That way MIMS has that big dashboard in front of them of every hospital in our area and all over the state. They can look straight at it and say, okay, they don't need to go to Baxter. They don't have ortho. The closest place would be White River. Let's get them to White River. That's how the dashboard comes about helping. Or is it a problem sometimes because we call on the AWIN and we want this patient to go we're looking at this patient eyes on and we're like, this patient don't need to go to Fulton County. They're saying go to Fulton County. At that point, you can argue and say, I'm going ahead and taking that patient to Fulton County. And then Tim needs to call down and talk to Jeff Tabor at the dashboard that's over the dashboard and resolve the issues. No, go ahead. Yes. 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 You have the right because you're looking at the patient. They are just listening to it.
So
And it,
Basinger says, is it feasible for EMS to bypass level 3 and 4 with a burn patient, adult, and go straight to emergency?
it is feasible if that patient is stable and you feel like it. That's really what they, at the beginning of the system, that's what they suggested is you take them to the nearest appropriate facility. And there's no burn unit around here besides at Springfield or at Children's and the med in Memphis. But most of ours go to Springfield.
Johnny Stolpitz was here last week, and he was sharing his experience about taking straight to Children's, and it really upset them because I guess yeah. Yes.
Yeah, true, but with a burn, usually you're not gonna need x-rays. You're just gonna. But do use your A1 and let them know you're on the way. Yes, ma'am. Yeah. Basically use your judgment. Whatever as a medic that you feel you're comfortable with, use your judgment. And if they critique you, you go to Tim and I'll talk a little bit about that later. Um, we now we all have A1s. That's what we use to call into that call center to see where to tell them where we're taking a patient. In Arkansas, we have four levels of hospitals, trauma centers. Our level 1 is Children's UAMS. We didn't have enough level 1s, so we took on some outside state line hospitals like Cox and Mercy and Le Bonheur, and then Region 1 in Memphis. Our level 2s is Baptist, St. Vincent's, and Washington Regional Medical Center. Our level 3s, the only difference in a level 1 and a level 2 is a level 1 is a teaching hospital and a level 2 has all of the things. They just aren't a teaching hospital. Level 3s around here is Baxter, White River, and actually what's it called? The complex?
MCED.
MCED is, they are also, because they were the only freestanding ED, they're the first freestanding ED in the state of Arkansas. The trauma disc system really didn't know what to do with it. So they made them become a level 3, like White River is a level 3. They don't have surgeons, so they really should be a level 4, but they've never really went back and rectified what, yeah, they just get a D. No, it's not, because they're really what they operate. It's a level 3. like Fulton County.
You did?
Gonna get them. And that's why with the trauma system, they try to educate where even us in the rural areas will have as much education and equipment as those in the urban areas. And that's part of what the trauma system was about. People in the rural areas was dying because they didn't have the ability to take care of them. And okay, Terry, I'll pass the mic around. Level 4s is around here is Fulton County. I have Calico, however, they are not redesignated. Fulton County, Stone County, Heber, and Clinton is the level 4s in our area. In EMS, you guys have a field triage that you guys go by. And each hospital you take your patients to, there will be we have a different criteria. We have to follow the criteria of the state, but we can upgrade our criteria. We look at our data, like we had motorcycle wrecks that was going over 15 miles an hour and they were getting killed. So we upped our criteria to where if they were going over a certain speed, we went ahead and called it a major, where you guys would call it a moderate. It's just different little things that we tweak by our data that we put in of how that we see that we need to adjust our data. But you guys, I would, if honestly, after working at the hospital and you guys being in EMS, in which I have a soft spot for you guys, I would just call in and tell them what I had. I wouldn't say major, moderate, or minor. I'd say, this is what I've got. You make the decision. Give them a good set, because even at Baxter, the nurse is not going to make that decision. She's going to run to the doctor and say, what do you want? Because every doctor has a different idea on how everything should be. So basically, I would give them a good report and say, and they'll decide what they want from that point. That way it keeps you out of having to be in the middle of it. Good set of vital signs. Trauma bands. We started that with our trauma system. And the reason why we put trauma bands on is we can track this patient through the entire course of their treatment. From police can put trauma bands on, to EMS, to the hospitals, on to rehab. That way, the state, we all put this data into a registry, and they drill all this data down. They have analysts that drill all this data down of how we can improve. So that's why the trauma band is important. For EMS, step 1, determine if the patient has had any traumatic injuries, minor or majors, within the last 14 days. It's 14 days. We have to put them in the registry from 14 days. She, 14 days. We'll cut that thing off. Hang on, let's pass this Mac over. Pass that Mac to her. Yeah. Hey. Dana asked if suicides was considered a trauma. If they're a hanging, if they have a slit wrist, any kind of injuries on externally, they're a trauma. We do go ahead and trauma ban them. A lot of times we just banned them, but really unless they have some kind of injury. In the emergency department, we look to see if a patient has a trauma band on. If it's there, we go ahead and put it in our record. If there's not a trauma band there, we're kind this way. We go ahead and put one on and we cut down the EMS and give it to them because state will ding you for not putting trauma bands on. But in this small area, we try to give it back because sometimes you guys are busy and forget to put one on that because that's the least thing on your mind right then is saving a life. So yeah, I'll call Tim or either I'll have catch the crew before you leave and say, hey, here's your trauma band. UAMS has a trauma image repository. What it is every x-ray, CT, or any scan we do goes into this repository and we push it over the system to wherever this patient is going so that Springfield can already have the records up. They can already be looking at the images. They can already have their team assembled. If they need ortho, if they need neuro, can already be there so that they can take care of this patient as soon as they roll through the door. That's another thing that's, what's he saying? Don't bring me a DOA, Mike. If you bring it in, even if it's a DOA, Mike, I know you're joking, but I think you're joking. But if you're bringing it to our hospital and it's ejection from a MVC or any kind of trauma, yes, you go ahead and ban that because we have to put that patient in the registry. If they pass in the field and you don't bring them in, then no, you don't put one in. But if you bring them to our hospital, yes, you put one on. Let me give this to Tim.
Got multiple patients and you have one that's dead. And then they leave it.
I would trauma ban them and put it in your. I would. That's a good question, Mike. I never even thought about it because I'm not on the EMS side. We also have the Arkansas Trauma Registry. The registry is where we put all of our data in to help improve care. And one of the things, not only is it for the medical side, but as I say, to improve care, we had a lady with 3 children that ran off in the lake and they ended up all passing. So they got the Arkansas Highway Department, they got them together with the state police, and they came up with the action that they would make the guardrail longer around that curve so that no one else would die from that. So it's not just, we put this data in for several reasons: for injury prevention, for better patient care, and for things like that. We have Q-Source, who is our quality people that pull charts from us and look at and review to make sure that our data is good that we're putting in the registry, because you can pull data all day long, but it needs to be good data and correct data. and they'll send it back to us and we'll fix it and then put it back in. So when they do run their reports, we have good data to go by. We have injury prevention. That's part of our deliverables for our grant. We are, as a track in our region, we're given so much money, and we're to look and see what in our area is an issue with injury. Most of our injuries, in which a lot of them is falls in the elderly, because we're in an elderly area. But we did a lot of that, and then we decided, after these drownings, since all of our people in our area has lakes, rivers, all of that, we decided to buy the window punches and the seatbelt cutters and give out to each hospital to go out into the community to educate on how to get out of automobile. Because right after we had that one fatality, the fatality of all those children, we had a guy that drove into the lake, and he was 30 something, and he called his mom from the cell phone and said he couldn't get out of his truck. So we felt like if everybody had one of those and some education on how to actually break out the windshield, and it would help prevent even one death. If you prevent one death, you've accomplished something. Um, and Fulton County does a very good job of documentation, because we see several. It also, part of the trauma system is rehab, because if you don't get good rehab, especially for spinal cord injuries and head trauma, that they're going to have this issue the rest of their life. So it's important to get them good rehab up front, to where maybe their injury they sustained, they will be able to do better out in the community when they come out. They give them lots of education. If we have a patient that come in and fell and hit their head and has any kind of trauma, we have to give them a book, and it has all kinds of resources in it of people they can contact, hotlines and all of that stuff for care for when they get discharged. And we have to put into the TBI registry every traumatic brain injury that we keep. We have to put that in there within 5 days in that registry, and they contact that patient or the family and start setting up, getting them the care they need and the resources they need for once they're discharged. We do telemedicine now, hand injuries, burns, snakes. We just started putting snakes to where that we were transferring a lot of snake bites out that we could have kept in our own facilities. So we do telemedicine through, they're from all over, but it's set up through UMS. A lot of you guys will remember. A lot of you guys will remember how we had such a hands shortage, in which there still is. Hand and vascular surgeons are few and far between. And back in when I first started here, and even Tim will remember it also, we EMS took people to Nashville, Tennessee, for like a guy turned a lawnmower over and put his hand up and the blade got him. He went to Nashville, Tennessee to get his vascular injuries taken care of. Where now we do telemedicine so that we know if they really need to go or not. So we don't fill up overpower the trauma surgeons down there that does vascular, but yet we get them to the care they need when they do need to be transferred. And we keep a lot more snake bites now at Baxter. We give them the Crofab and keep them than what we used to, because a lot of the surgeons wasn't comfortable and they would go ahead and transfer them. Our surgeons still balk a little bit on keeping them on the extremities. How the system is formed, I'm kind of jumping around here, But how the system was formed is, when they started the trauma system, they said, how can we get everybody involved? Because you've got, most things happen in Little Rock, it's urban. We're not urban, we're rural, very rural. And most of the places around here is rural. So they said, we'll pick out regions and they will have a track, which is a trauma regional advisory committee. They will meet in all of these areas, and then it will all come back to the TAC at Little Rock, which is called the Trauma Advisory Committee. And a medical director from each track sits on the TAC at Little Rock. So our track is Fulton County, Stone County, Baxter, White River, MCED, Searcy, Clinton, and Cox, because they put a level 1 in each track. We meet every 3 months. EMS and the trauma medical director, the coordinators, and Dr. Dickinson is our trauma medical director. We meet, we bring our issues together, and then we meet every 3 months. And then every 3 months, the day before that, the TAC meets. So Dr. Dickinson goes to Little Rock and takes our issues down there. And so does all of these outlying areas, so that everybody gets a voice in the trauma care in their area. It's not just made in the urban area, which I think is great, because usually us rural people kind of get left out. We love y'all. We also have quality improvement, that we are mandatory that we meet certain guidelines. Like I said, Q sources are contracted that they review our data. We have what's called clinical practice management guidelines, and there's 4 of them that we have to do: traumatic brain injury with anticoagulant, an open fracture, geriatric, and femur fracture. And on the traumatic brain injury, we have to make sure that they get Keppra to prevent their seizures, and a reversal if they need it, and which is hard because all of the new drugs that come out, the Eliquis, Pradaxa, and all of that, the antidote for that is about 40,000. So yes. So if you're on those and you go to a level 3 hospital, you're not going to get that reversal because no one can afford it. The only hospital that actually has it, I think, is a hospital in Texas. Now Coumadin, we'll give them vitamin K. We'll give K-Centra, that helps some. But
So that's why it's important to know what blood thinner.
That's why it's important to know what blood thinners.
Okay. Okay.
Did they hit their head?
Okay.
And yeah, yeah, they do. Mhm. Emma's talking about a lot of your patients think that aspirin is a blood thinner. We don't count that as a blood thinner, but to them, they think it is a blood thinner. So just make sure when they say they're on a blood thinner, find out what kind of blood thinner it is. The good thing about when they're on Coumadin is we can give them vitamin K and reverse it, but people don't really like to take the Coumadin because they have to have blood work drawn all the time and it titrated and all that, where the other drugs you don't have to.
And I know.
We count Plavix also as a blood thinner. On our open fractures, that's why you have ANSEF on the truck to give within 1 hour of injury. Is they figured out that on an open fracture, to prevent infection, it's better, the sooner you give ANSEF, the better off you are. I know sometimes you may not know if it's an open fracture or not, but if you've got a poke hole above a bone that's broke, go ahead and put the antibiotic in. A little antibiotic. If only thing could happen would be they have a reaction to it and you got epi and Benadryl.
Thought they needed surgery.
That's what I'm saying.
Yeah.
If it's not going to hurt them, go ahead and give it if in doubt. because you guys, some of the people y'all get, the ANSEF's supposed to be given within an hour. And by the time they extricate these patients and you guys get to us or wherever you take them to, your hour's already up.
Yeah.
So go ahead. We give 2 grams. You guys give 1 gram, but at least if you get 1 gram in, we can do the other gram once you get there. And I think since y'all have went with Baxter, I would say you'll probably be going to 2 grams. Tim said it is going to change to 2 grams. Hang on just a minute, Tim. Tim said, Tim said that the thought prospect, it's a
You
drip.
mix it.
Y'all have to mix it, but you'll actually. What does y'all's protocol say? Over 10 minutes? Tim was saying that back in the beginning, when they started this out with you guys giving ANSEF, they decided on 1 gram because it was a cost issue. But now with you guys going to Baxter, it'll probably be that you'll go to their protocol. You are going to their protocol, so it'll be 2 grams.
So Basinger asks thoughts on giving ANSEF to burn patients.
It's not anything that is required. I do not know that. What do you think, Tim? Tim said he doesn't know either. Burns is not really something that we track through the clinical practice management guidelines.
But it's a trauma.
But it is a trauma. It is a trauma for sure. Yeah. Yeah. I don't think y'all could do that without it being in your protocol. Tim said that you can get a verbal order, but you can't just give it if you don't have a protocol for it. Maybe that's something Tim sits on the EMS committee. Maybe that's something he could bring up through their committee to see, and they start researching and see about maybe if it would be a benefit or not. That's what the committees are for, is so that everybody brings their data together and tries to improve the care. Our other clinical practice I can't even talk. Management guideline is geriatric. Every geriatric that comes in that's 65 or older or any age that fall and hit their head, they get a CT within 30 minutes. And getting all of these geriatrics to the CT scanner within 30 minutes is very difficult. So when you call in report, make sure that you tell us that they fell and hit their head. We review every death through our quality program. Each hospital is required, like we have the track and the TAC, each hospital is required to review their charts through a committee also. And at Baxter, the EMS sets in on it, administration sets in on it, nursing sets in on it, ICU nurses set in on it, PACU nurses set in on it, ortho, neuro, anesthesiology, radiology, we all set in on it. We review our charts. Me and Charity looks at the charts. We pick out what we think needs to go, but all of our deaths have to go. And then we take it to Dr. Dickinson weekly. He decides whether it needs to go on, or me or him or can sign off on it. And then we take it on what he thinks needs to be taken on. We take on to that big committee, and Allison has sat in on those meetings before. Feedback is very important, and I realize I'm not very good at that, and I promised this year I was going to get better after redesignation to giving feedback to all EMS crews. We get a lot of patients in, but I know that you guys want to know what happens to that patient once it leaves your hands, because I want to know what happens to my patients when we transfer. And so I will start doing better at that. And if you guys ever have any questions on any patients and want a feedback, you just call me and I'll give you feedback on your patients. I don't care to at all, but I will try to do better on that part of it. Questions? Anybody online? Allison wants to know again who all is on our track. Yeah. Fulton County, Stone County, Baxter Health, White River Medical Center, MCED, Searcy, Clinton, and then Cox. Thank you, Mike. Kim has something. Yeah, we used to have, here, you,
I'm glad you're making him, because he won't listen to me.
Okay, Harris Hospital, which is now using Harris Hospital. They're in the northeast right now. I'm sure they're there.
mhm.
Mhm.
White County, are you talking about White County? White River? Mm.
Is yours, that mic still on? That mic still on? Okay. And I'm on.
Tell them I said thanks.
Tammy said, thank you. Here.
I skipped jumping. You hope. You hope. You do.
Yeah.
I gave him a big old manila envelope.
This one.
Hang on just a minute. They want to hear.
No.
Yeah, they do.
Actually,
And how you,
Right, try now.
where's your
they're
mic?
probably all.
No, they ain't. They're still up there. Tess. Where's your mic?
You know now.
Say, can hear. Can you hear?
Can you hear me?
Start singing to him.
Well, a little story, and basically, you know, what I thought was
I may have turned it down.
hate reverb. Absolutely. Okay, anyway.
Just a minute.
There you go. Now go.
Okay. Long story short version, this is a Cliff Notes version. I was the EMS director, had been one for maybe a year-ish. Tammy brought me a stack of paperwork about the Trauma System Act that had passed in '09, and said, would this be beneficial to our little hospital here? I thought, well, she just didn't want to do this. I'm stupid enough to do it. So I looked at it and came up with the pros and cons and gave it back to her. So long story short version, in 2010, she and I started working on gathering all this data, equipment, begged, borrowed, and stole, basically. So a year of our life was, year plus actually, was spent gathering data, going through the PRQs, et cetera, et cetera. Long story, in May of 11, we were the second level 4 hospital in the state of Arkansas that was approved for trauma. And it was Tammy's hard work, because I was a gopher. She'd say, go get this. But she did all the hard work. But the reason I'm saying this is a good thing is because we were included in the trauma system, meaning FCH EMS. We had antiquated equipment when I got here. You can talk to Big Mike, Randy Fowler, David Martin. We had what we had. We weren't able to purchase it because we didn't have the money. When the trauma system came to be, they allocated X number of dollars for every hospital, every EMS agency. And EMS is based on a volume and some other factors. Essentially, we get about $20,000 a year, and that's used for equipment and education. We can go out here and look at one of these trucks here at Fulton, and I can point out stuff that we would not have if it hadn't been for the trauma center. That's your power cots, that's your Lucas device, your video laryngoscope, amongst stair chairs. But well, cardiac monitors were actually a Blue Cross, but it was grant money. Yes, it was Blue Cross.
Part of your ambulances.
Part of the ambulance offset cost was from the trauma system. But that being said, that's great to have the equipment. But the big advantage here is every year there's 3 conferences, at least 3 that I send medics and EMTs to. And that's the Redfern, which is Pete, that's Arkansas Trauma, which is in Little Rock, and the David Miller in Springfield. And last year with Northwest Arkansas, you think of the name of that conference?
Rogers.
It was a fire EMS conference. And I can promise you that here at Fulton, we've had more people sent to trauma conferences than any service we're in. Go to Baxter and ask them how many times they've sent somebody. White River does occasionally send people, but I'm pro education, and that's where you're going to learn, because we don't do as much trauma as Metro or as Baxter or as White River. So you learn what's new in the field and also in the hospital setting. It's not all about EMS. You have hospital and pre-hospital that they cover. You have premier trauma surgeons in the nation that speak at these conferences. So we would not have the education that we have now or the equipment here at this little ambulance service if it was not for the trauma system. I'm very pro on trauma system.
Yeah, even at Baxter, we started doing, when we went to our last trauma update, we changed our protocol on mass transfusion protocol, where we started adding the calcium and the vasopressin. I mean, that wasn't something that we were doing prior to that. And we had been at the conference and been back a couple weeks, maybe. Like, we didn't even have the protocols fully written yet. We had a lady come in MVC, and yes, it was a shit show, but we gave her all of those things, and that lady's alive today. And I truly believe she's alive today because we did what we did.
Well, it's
And it was just
I'm
the,
sorry.
yes,
Sorry.
yeah, it's just better. I mean, it's just like with T&K, you know, we're going to be, right now it's door to needle in 60 minutes. I guarantee you within the next year, maybe 5, they're going to bump that to door to needle in 45, because everybody's doing it right now.
Good.
And it just I mean, it's just, you know, it's evidence-based practice that shows you the vasopressin, the calcium, you know, you can form the clot with the calcium, given the blood, not given the fluids, because fluids don't work. You know, it's just, it's definitely a big, I like the evidence-based practice.
May the 17th and 18th is trauma update in Little Rock.
One thing though,
Another
sorry,
thing-
go ahead. No. in my opinion, as many people can go should. And I'm not bashing doctors, their time is precious, just like everyone's. I think more ED doctors need to go to the trauma updates because I'm not critiquing them, but some of the practice is, in my opinion, antiquated, that they're using medicines, doing procedures that 30 years ago was state of the art, but it's not standard of care now. And one thing in physician at Baxter, we're actually friends, but we butted heads over TXA. Well, every major trauma conference I've ever been to, these premier trauma surgeons says, give TXA, give it.
Every 3 months, when we do our big trauma meeting, Allison knows we have a education for an hour. And you can get a CME for that hour of education, and we have good speakers, the physicians speak. Dr. Taylor is one of the best out of Arkansas. He actually was at Pine Bluff. He spoke one time. Dr. Giardo talked last time about how building the wall has made more injuries because they built the wall higher and then the people are falling farther. So I can get everyone's email and set you up a Zoom link.
Yeah.
And because now that you guys are with us, and I can send that out and you guys can get on and watch the education.
We'll just have to make sure we send them
I just need to get a list of
the
everybody's.
UAMS part so they can sign up on the
Yes,
cloud
you have
deal.
to sign up. Did you sign up on?
And I haven't been able to figure it out.
It's Learn on Demand, isn't that what it is?
No, that's stroke. It's
The CME cloud,
Some
whatever.
cloud
Yeah.
thing, yeah.
I'll send out the link for y'all to sign up on that, and it's through UAMS, and we pay for that, and you guys can get, you know what, though, I don't know if now, you should be able to since you're part of us.
Yeah.
Let me make that for sure.
Mhm.
Okay.
But you can still listen to the education, but you should be able to get the CME also. Sometimes speakers not as good as others, but there's a lot of good ones. Yeah, you went last year.
Mhm.
Mhm.
Mhm. We'll never get whole blood.
No.
UAMS is just now getting whole
Yeah.
blood.
Yeah,
Red Cross won't.
yeah.
Red Cross is really balking on it
I think
because of
Pine
the
Bluff,
shortage.
I think Pine Bluff gets it just because they have a gunshot wound
That's a
thrown out of the
gun,
door
not
like
a
every
gun
other
club.
hour. So I think they can go through it pretty
Man,
good.
I've
not
got to
wasting
get some
it.
stuff done.
It expires.
So
Oh,
we
okay.
learned in our first day of PHTLS that survival flight is now carrying blood.
They do, yes.
Yeah.
I thought
They
air
carry
back
blood.
did also.
They do.
Mhm, They do, yeah. Both of your flight crews
Yes.
carry blood. We had a patient come in the other day that survival flight had started blood or air back.
Girl, don't give me
Which one does?
Girl, don't give me a lot.
Everybody.
Everybody. You had blood hanging. Yeah. Yeah.
What do
We
they,
had a-
they carry blood and
Platelets.
platelets, yeah.
Yeah, they got the one when they do that.
How do they do the blood test to make sure patients have it?
They don't, they just take.
Oh,
neg.
Okay.
Okay.
Neg
We
is
have
universal
two
donor.
units of
Everybody
OMEG
can have
actually,
it.
and OPAs in our refrigerator in the
Mhm.
ED
Oh, okay.
that we can grab out.
We don't even have to go to lab. for it. We
We're
can just
one of
go
the
to
few
refrigerator and
hospitals
get it.
that have a fridge in
Oh,
the
that's
ED
nice.
because most labs won't turn loose with. Blood is such a shortage,
Mhm.
and I mean, it's very expensive.
Mhm.
So they try to rotate it out and keep it to where that we never lose a unit. So,
Okay.
because Red Cross is real stringent on,
Oh, are they?
very stringent.
So I know that the state of Arkansas, my dad likes to donate to them.
there's some blood drive that happens down in Stone County.
Mhm.
Does Baxter or Fulton County ever have access to
I
blood drive
think
that's
we
Arkansas based?
use.
We use Red Cross.
Yeah, we use Red
Yeah,
Cross,
we use
okay.
Red Cross.
White River doesn't. White River used Red Cross and then they changed. They
There's something out of
use
Memphis.
something else. I can't
There's
remember what
Memphis
it
and
is.
Oklahoma has something that's not Red Cross. Basically, who you can get a contract
Hmm.
with.
Okay.
You have to have a contract with them.
I don't know if this is still being done, but years ago at Batesville, if you thought you as an individual were gonna have to have surgery, for whatever reason, you could have people that you knew, as long as it's the same blood type,
Mhm.
donate it and they would keep it. And if you had to be transfused, they would use that blood.
I don't know if they do that.
That's been a long time ago, 30 years ago.
There's actually where people are gonna have surgery.
They can give their own blood. Mhm.
Can actually draw off.
Mhm.
Do they
They
actually
accept from
donate
somebody
blood?
else.
They'll donate
I
blood?
thought what we learned last week though was that there's some Jehovah's Witnesses that want to take their own blood. Like,
Correct.
it's removed from your
Yes.
body and so on. Like a
There
dialysis.
is.
What is it they will take?
Albumin.
Albumin. They will take
It's a
albumin.
protein.
Some of
I had
them,
a-
some of them will take parts of.
I had one ask me
Yeah,
once when I
some of
started an IV, you know, in the chamber, you get that little bit of blood. They didn't want that put back in. I
Why
said,
would you
"Hey,
draw
let me
and
tell you what," I
flush?
said, "Okay." They were looking around, I just went ahead and pushed the flush. So, I mean, what was it supposed to do? How am I gonna get that out of there?
Well, it's still kind of
Somebody
in
tell
there.
me,
Closed
please.
unit,
Pull
like
it.
a dialysis, is what they
Yes.
said.
Clamp it, pull it,
Yeah, that's.
get you another flush.
All while you're running down that road about 60 mile an hour.
Yeah.
Yeah.
A distracted, like, what is that?
Yeah.
Yeah.
And about that time you'll lose your IV.
Yep.
Any more questions for me?
Any more questions out on Zoom land? We'll give you just a few minutes to get them in if you do.
Hmm.
Thank you so much for coming and
You're
doing
welcome.
this.
I enjoy it. I
We
love
do it a
trauma.
lot.
I love trauma. That was my
Well, I
Just
learned
makes me tag
something.
along with
I'm definitely in the geriatric.
it. You're in the
Stop it.
geriatric population.
Yeah, the hit ahead, he's old.
You hit both
Because
criteria.
you're on
Because
Eloquist.
you're on
and-
Eloquist. We're going straight to C2. And I was gonna, when you guys call report in, you're coming to Baxter especially, script them. Say, hey, I have this patient that's fell, they hit their head, they're on Eloquist, I've got a
Oh.
hematoma over their right eye. Do you want me to meet you in CT? Script them. Same way with you, if you happen to pick up a stroke and bring it over there. Hey, this patient's having a stroke, I've got right-sided weakness, I've got obvious deficits. You know, this was in the last hour. Do you guys want me to do you want to meet me in CT? Script them. Because it helps. It's something that
Are we gonna get any blowback from that from the nursing?
if you do, you call me on the phone.
Well, what I found over
Oh.
there, and correct me if I'm wrong, but the nurses sometimes can use that as their argument to take to the
They
docs.
can,
They
yes.
Hey, EMS
Right.
is recommending.
Hey,
Okay.
EMS said this is,
Because
yes.
nurses aren't
Yeah.
allowed to make that
Yeah,
decision.
and if you get any
independently.
lip from the nurses, let me know.
Because didn't they try
Only
to
have
make a
one
protocol
time.
where the
We
nurses
have
could
one.
determine that, but
Yeah.
the doctor was like,
Correct.
We
we didn't
still-
want nurses to
We
be
still
able-
fight it.
Fight it every day
Every day.
about
But
that.
yes.
You would think that would be easy.
Stroke and if they fall,
What?
it's black and white.
You would think.
But now, in their defense, I had a nurse that decided that this kid, 4 years old, fell and needed a CT, and she knew the doctor wouldn't order it, so she put the 65 and older protocol in on it. Now, that causes an issue.
That causes a
65
problem.
days or older?
Yeah.
You
it
have
was
to
an
use your
issue.
protocols correctly, or
Appropriately.
they lose
Yes.
competency.
But sometimes even in the nurse, I mean, and I'm a nurse, I'm not, I mean, I'm not defending this too, but if you script me, I'll be like, oh, well, shit, yeah. You know,
Yeah.
I'm busy, I'm doing 12 other
Yeah.
things, but if you say, hey, you want to meet you in CT instead of me just being like, oh yeah, room 15, oh yeah, let's go to, yeah. Scripting helps.
I've had a couple of nurses go.
Yeah,
because
yeah,
the doc
scripting
won't
helps, yes.
Say yes,
Mhm.
but if you're saying it, I can get it.
Well, I know here when they first. They're on the set. Doc actually got.
Yes, here is very easy, and so it got
It's a little bit of education, but really initially at that when I started here, the doctor would be the necessity for ever about that. Is it a money concern, a paperwork concern, like what's the difficulty?
You ever heard of cats?
Yes.